Well, welcome everybody from around the world who's here to listen to me a bit about proper burr selection for restorative procedures. This program is brought to you by myself, Mark Geisberger, and Microcopy Corporation. So I thank my sponsor for being here in support. So let's go ahead and get started. Just briefly about myself. First of all, I've been in the dental education industry for a little over 27 years as a full-time professor at the University of Pacific in San Francisco, California. I taught there for 27 years consecutively and just retired this last February to become an adjunct clinical professor. I'm really devoting most of my time now to my private practice in Marin County, California. In addition, I do a lot of product evaluation and work with a group out of Chicago called Catapult Education. Catapult Education is a large group of speakers and product reviewers who help companies come to market with different products. So, thanks and disclosures. You all listening need to know that Microcopy Dental has sponsored this program and is underwriting the cost to Viva Learning of me being here. So I want to thank them, our sponsors. With that said, Microcopy Dental is at microcopydental.com. Feel free to look them up and check out their products that we'll talk about today. So in addition to that, Catapult Education, as I mentioned, is an online group of speakers. Go ahead and check us out at Catapult Education if you'd like. All right, and these are Catapult speakers. They're a great group of people that I work very closely with through Catapult Education. You may have seen us out and about on the lecture circuit, but take a look at us and check us out online. So let's talk a little bit about some of the learning objectives I'd like to help you with today. First of all, I'd like to talk a little bit about what types of and designs of burrs are most appropriate for today's modern ceramics and composite restorative materials. Then I want you to really think about how to maximize cutting efficiency and decrease wear and tear on your handpieces. And there's some strategies I'll discuss as we go through the program that can really help you do that. Then, what strategies do you employ to manage burrs in your practice? If your practice is anything like mine, you've probably got more burrs there than you actually need or use on a regular basis. So how do you help eliminate some of the unnecessary burrs? And then finally, what do you need for gross reduction, contouring, finishing, and polishing? So we'll go over all of this, and I hope by the end of the program I've identified some key things that may help you with enhancing your preparations in private practice. So why single-use burrs? Now, Microcopy is a manufacturer of single-use burrs that are disposable and they're single patient. I'll tell you some of the real benefits I see with single-use burrs. First of all, you reduce the risk for cross-contamination by eliminating transferring burr from patient to patient. And keep in mind, we're cutting into tissues when we use a burr. Number two, single-use burrs, because they'll be sharp each and every time, will greatly reduce the wear and tear on your dental turbines. See, as you use older burrs, because they're not as effective at cutting, when you lean on the handpiece to increase the cutting efficiency of those older burrs, it really torques your turbine and can predispose the turbines for early failure. So using single-use burrs really helps reduce that. Using single-use burrs can really help you maintain stock by really focusing you in on the burrs you use on a daily basis. Another thing is it'll increase your efficiency for each dental procedure. By that I mean each and every time I sit down, my burrs are brand new and I know the procedure will go smoothly and efficiently. I know it's frustrating using sterilized burrs when you get a burr that really has lost its cutting edge and you can't work efficiently anymore. And that can be a real distraction to you and your practice. And it'll decrease the number of times your dental assistant has to get up to retrieve products during a procedure. I can tell you, I used to use sterilizable burrs. What would happen is we'd be cutting and I'd cut and cut and cut and leaning on the prep. Nothing's happening and she'd have to get up and get me another burr. Now I put the Department of Veterans Affairs on here for a reason. And that's because the VA has been really one of the first big organizations to adopt the concept of single-use burrs for their entire operation, which I think is quite impressive. So let's start with some simple direct restorative procedures. And I'm going to give you just a few tips here with burr selection. First of all, we've got to recognize that there's been a huge shift in the educational trends of how we're taught preparations for direct restorative procedures. If you look here on the old amalgam prep, this preparation was created using square burrs. Oftentimes we'd use an 856 or 855 type of burr or a 55 carbide burr. This burr is created with round burrs or pear-shaped burrs. The whole idea here is with composite preparations, we want to stay away from these square, sharp line angles that we used to create for amalgam. We did this over here to help with retention and resistance form. Here, because we're relying on our bond, we can be far more conservative, create pits of decay removal where necessary, and leave the tooth far more intact when we're done. So really, the prep that we used to do, that so-called gingerbread man shape, has really been replaced with a far more conservative preparation that requires a slightly different armamentarium from the old 55 or 56 burrs we used to use. And that's important to recognize. Keep in mind that, we used to monitor a lot of things, but now with smaller Fisher burrs, we can come in here and open up these grooves very conservatively and place a sealant material to restore those teeth. So what we used to do is kind of watch these until they're large enough, and then we'd go ahead and restore them. Well, that's problematic because in reality, that creates some issues for us with conserving tooth structure. So to be more conservative, we're going to look at certain burrs that I'll talk about in just a second. Now, because prep design is so much more conservative, and we're using small burrs and trying to create relatively small preparations, we need to be able to protect the adjacent tooth. What's demonstrated here is the use of what's called an interguard. This interguard is actually sold through a company called Ultradent out of Utah and is a great way of protecting adjacent teeth. So prior to preparing, I'll slide the interguard in here, and now as we cut into this box and move our handpiece towards the adjacent tooth, we won't damage the adjacent tooth. So this is a very good way to be extremely conservative in your preparations and prevent damage of adjacent tooth structure. Here's an example. Oftentimes the decay is sitting lingual to that facial contact area, and you'd love to leave that intact. However, oftentimes we'd extend out here just for convenience form. What I now do is slide an interguard in here, an interguard in here, remove just the decay, and keep the preps as conservative as possible. Remember, the best human contact is the one given to us by nature proximally. So let's talk a little bit about some of your choices in burrs. When we look at that preparation where we talk about being very conservative, there are a couple of approaches that I like to use. First of all, if you like diamond burrs, your diamond approach would be using one of two burrs, a pear-shaped burr, and this happens to be Microcopy's medium grit 0508 burr. And that's been used to create these small round pit preparations and open up very conservatively through this isthmus here. But when we have decay that extends up these little grooves and we want to be a bit more conservative, as we see here, here, and here, I switch to a 1509.3 burr. And this is a little Fisher burr that's pointed and can be very effective at getting into those smaller grooves. Now what I do generally is restore this occlusal surface with a conventional composite, and then even consider using a small sealant material or a flowable composite into these three little grooves. but I think these burrs are ideal for that clinical situation. So what about for your standard little operative preparation? I think the workhorse of my practice is Microcopy's 330 burr. This burr is disposable. Each time I open a sterile package, I get an instrument that's extremely sharp, creates these very nice finish lines along our preparation, and creates an internal aspect that is round in nature. The reason we want round is adapting composite to a square surface or 90-degree surface is actually quite difficult. So rounding off our preparations initially makes us more efficient. And we don't want to have to go back in with a burr that we would conventionally use to square up a preparation. Rather, we want to do the entire preparation in the simplest fashion with one burr. We'd slide our interguard in here, create this box form using the same burr. We'd bump up against our interguard and not damage the adjacent tooth, and be very efficient at cutting our preparations. And really, this is my workhorse burr. 90% of what I do in the direct restorative side of things occurs with this little burr. Let's talk about Class 5 preparations. Class 5 preparations conventionally were taught to us with a standard bevel. And to do that standard bevel, you'd really use the side of any burr. Your 330 burr would be just fine at that. What I recommend is the use of an irregular bevel that varies not only in height, but in depth on your preparation. So once you've completed your cervical preparation and eradicate the disease, I'll come back in here to the occlusal portion and place my irregular bevel. Now honestly, I'll do all of this preparation with my 330 burr. However, if you want to use your pointed diamond burr to do these little irregular bevel, you could use that one as well. So let's take a look at a clinical case. Here's a clinical case with very large abfractive lesions on these maxillary premolars. What I do first is come in here and place a cord. Then I'll come in with one of two burrs, a 330 burr from Microcopy and do my irregular bevel, or that 1509-3 burr to come in here and do our irregular bevel. Either or will work. If you're trying to eliminate inventory, stick with the 330. Once this irregular bevel takes place, I'll restore these with a total etch technique. So in this case, I'm using Scotch-Bond Universal from 3M and Filtech flowable composite to restore this completely. So we've got our bonding agent in place, we've cured that, and now what I'm doing is placing the flowable composite into the occlusal portion first, and I'll carry this up towards the cervical. Once that's completed, I use a very simple finishing system from Microcopy. It starts with an EF9, which is a carbide finishing burr, 12 fluted burr that's very effective at shaping and the facial aspect of both of these composite restorations. What it does is it will help you cut back to your bevels, and if you notice, you're having an impossible time seeing where my restoration begins and the tooth ends. And then to give these a polish, go ahead and try Microcopy's Gazelle polishers. I would use this two-step system using the cups over the points in this clinical situation, and it works extremely well for a Class 5 preparation. Now, here's the simple thing in composite finishing. You need a simple, small inventory. And my inventory really contains only two types of burrs. First of all, a straight carbide burr like this. This is going to be used on smooth surfaces, say the facial anterior teeth or Class 5 situations. And then I'll have this H274 burr, which is really designed to be used on, say, the occlusal of tooth structure to establish some primary anatomy. You can use the tip of this and the lateral side of this to create some grooves along your class 1 and class 2 composites. Then to polish, use a simple disposable sterile system like this, a two-step system that gives you a great luster very economically, and it works extremely well. So really, if you look at it, our operative kit at most will contain 6 items, and that's it. It's a very simple protocol for our operative procedures. Now, let's switch modes and talk a little bit about indirect restorative procedures. And we're going to talk a little more in depth about these and really some of the pain points and pitfalls in indirect restorative procedures. So to begin, we'll talk a little bit about some of the paradigm shifts that have occurred in all ceramic restorations. The reality is, back in the day when I learned to prep a PFM crown, it was all about being square, parallel, and sharp. But really, now our preparations are far more rounded. We want to avoid sharp internal features because they can propagate fractures or put stress points in ceramics. And we really look at more uniform finish line design. We've moved away from a conventional 90-degree shoulder to either a heavy chamfer or a modified shoulder. And that modified shoulder would be a round end shoulder burr, not the conventional square burr. And we'll talk a little bit about some of these changes. So prior to preparing any tooth or multiple teeth for indirect restorative procedures, I think it's critical that you ask yourself some questions. And first of all, before you start prepping, what is my restorative material of choice? By this, do I mean, are you going to use lithium disilicate, a zirconia product? Are you going to do a conventional gold crown? But what restorative material will you be using? The second question I ask is, do I intend to bond the restoration or cement the restoration? Now, most of the time, we make that decision at the time of delivery. But let me tell you, some of the protocols and reductions required for certain restorative materials are really based now on whether or not you intend to cement or bond. So we'll get more into that. Then, what technique does my laboratory technician use for each material it employs? So for instance, if your laboratory technician is an Emax user, do they press or mill it? Now there's a reason we have to ask that question ahead of time, because really the prep requirements for pressed and milled are slightly different. Then, what about zirconia? Am I going to ask for a monolithic material or a layered material? Because in reality, even though we may call it for a zirconia crown, each of those two choices requires different preparation design. And then, what zirconia actually use? If I'm going monolithic, will it be the conventional version or a more translucent version, which may require greater tooth reduction for strength? So let's start with a patient. We look at this patient. She's an older patient who comes in and really wants an aesthetic refresher on those anterior case that she had done multiple decades ago. Now this case presented at the dental school, and a student was working on this case and called me over to help him out. And the first thing I think I want to focus on is the long axis of these teeth. Now when you look at our patient's face and the crowns, it's obvious that these teeth all lean to the patient's left. And that's an important observation. Not only that, this patient has some gingival recession, and these margins have been patched, I surmise, probably for aesthetic reasons, if nothing else. And we've got these issues. So we get back and we look at our frame of references, the face, the lips, and the gingiva, and we recognize that we want to enhance things as best we can, given the fact that this is really a difficult clinical situation. So it all starts with this, and this is registering the horizontal and vertical planes using either a stick bite or say a Coyce facial plane analyzer from Panadent to register the vertical and horizontal positions of the ideal plane of occlusion. Once we've got that, what we instructed the student to do was to begin to do a wax up with the ideal long axis of the teeth created. Now here that's been done to a horizontal plane that's parallel to the floor when the patient's head is in a neutral position. And what we start to notice is this gingival architecture difference that may require some aesthetic crown lengthening. So keep in mind that this patient had the old PFM design. And really, when we take off these old crowns, they weren't ever prepared for ceramic restorations, which means we'll likely have to modify a preparation from a traditional PFM design, which is really more present here and illustrated here than here. But really that prep was earmarked by a shoulder on the facial and a more conservative chamfer design on the lingual. It had very sharp line angles and point angles. And really when we convert one of these preparations from a PFM to a more conventional ceramic restoration, we'll have to be a little heavier on the lingual, and we'll have to remember to round over any sharp point angle to establish really smooth, continuous preparation design. So how do we do this? Well, first of all, we've got to get these old PFMs off. And that can be a real bear, especially if you're using old burrs that have seen far too much work in their day. So what I strongly recommend for the removal of old PFMs is two burrs. First of all, you want to start with a diamond burr, and that diamond burr is used to cut vertically through the existing porcelain. Once you've cut through to the porcelain using that 11/16-8 burr, we would switch to this burr called a Neo Max cutter, and it's the Max 2. And this burr will effortlessly cut through the metal to allow you to then use a crown spreader to safely remove these crowns. So to begin this preparation, we'll cut off these crowns, multiple crowns, using those two burrs. Now, when we look at this and we superimpose our stick bite with the preparations, we can tell that everything leans to the left. And it's really interesting. I didn't know why this was until observing dental students for about 10 years. But here's my observation with dental students. Most dental students are right-handed, and when I would sit and observe dental students preparing multiple teeth for crowns sitting on the right side of the patient, I began to notice a pattern of preparations. What would emerge were preparations that individually had ideal taper with them, but collectively would lean to the patient's left. And I also noticed that the further away you got from the right side of the operating field, the more the preps would lean to the left. Now, I observed this time and time again. And then I began to work with left-handed students, and I noticed that their preps would always lean to the patient's right. So I can tell you without even knowing who this practitioner was that they were in fact right-handed. And because of the way they sit and position themselves chair-side, they lost track of the long axis of the teeth. So these preps were skewed to the patient's left. Now, to prevent this from ever happening, what I strongly suggest is prior to prepping multiple units like this, you make yourself an incisal reduction putty. Now this putty is made with a standard VPS putty, and it's done over the diagnostic wax-up. So you can tell here that this wax-up's been completed, the incisal architecture has been established, the cusp tips have been established here, and as we go in and prepare a case like this, we'll use the incisal reduction putty to gauge the amount of incisal reduction we've done and to help us along each preparation on the long axis of the tooth. Now, I'll be honest with you. I'm left-handed. This is a case that I prepared. And if you notice here, on my side, tooth number 10 is in perfect alignment, as is number 9. When we get over here to number 8, my tendency is to start tipping things towards the patient's right. Take a look at number 7. For a lefty, this will always be our most challenging preparation. And if you look, this long axis is slightly shifted off. Now, what this incisal putty tells me is that I'll have to come back in and taper the distal aspect of this tooth to regain or reestablish the proper long axis of these preparations. To do that is pretty simple. We'll take out our 1116-8 burr and just correct that. Now, this is another type of putty I've made from the same type of guide or wax up, and this one I've sliced horizontally midway through the tooth. And I've created a window that allows me to look at lingual reduction as well as facial reduction. And this is a real handy putty to use when you're trying to assess the amount of facial reduction you've done. Now, if you look, this is that 1.2 millimeter of facial reduction that's required. But I'm really good right here at the line angle, right here at this line angle, but straight facially, I'm underprepared. And this is a pretty typical phenomena. So what this putty allows me to do is assess that, go back in, and reduce the facial aspect of that preparation just a bit. It's quite helpful in doing so. So let's talk a little bit about restorative materials. First of all, is your lab going to use a monolithic zirconia on posterior teeth or a layered zirconia on anterior teeth? What materials are you going to use to prepare for the case? Remember, that was the question we asked up front. Well, if we're using the conventional zirconia with very high flexural and fracture toughness, we can be far more conservative in our preparation. But we have to keep in mind that as the true translucent examples have emerged on the marketplace, their overall flexural strength has decreased by about 1/3 overall, which means these materials are not as resistant to fracturing. With that said, if we're using a translucent version of zirconia, we need to be cognizant of the amount of occlusal reduction. Where with conventional zirconia, we can get away with a minimum of, say, 0.5, although that's stretching it, to 1 millimeter. These more translucent zirconias, being slightly weaker, would require more like 1.5 to 2 millimeters of occlusal reduction. So knowing what translucency zirconia you're going to use really dictates how much tooth structure you may choose to remove from the tooth. So take a look at another example, Lava Plus or Lava Aesthetic from 3M are beautiful materials, but these materials require a bit more tooth reduction over the functional areas than, say, the conventional lava ceramic wood or a conventional ceramic material in the zirconia variety. Now, let's talk a bit about Emax or lithium disilicates. As you know, Emax comes in either the pressed version or the CAD version. And really, the difference here is one is going to be waxed and pressed in the case of the pressed, and one will be manufactured by a burr and from a block. Now, it's important to recognize that the pressed version requires slightly less tooth reduction than the CAD version. Reason being is your ceramist can press this down in very thin areas to about 0.3 millimeters in the case of a veneer, where this, the best you could mill to would be about 0.4 or 0.5 in the case of a veneer. So you have to be really careful when you're trying to do conservative preparations with these type of materials and know whether your lab is a presser or a miller. And that's one of the questions we asked up front. Now, some of the benefits to Emax are real good strength. It's etchable and bondable. There's lots of opacities and translucencies that are available. And it's a beautiful material to use on a routine basis. So let's take a look at a patient and talk a little bit about some of the prep designs and some of the nuances you may come across in private practice. So this patient presents in practice and wants really an aesthetic refresher of some anterior teeth, and we decide to do some various preparations with this patient. Now, she was aesthetically oriented, and you ask, what do you do? What materials do you use? Well, I chose to use Emax in a relatively translucent opacity except on one tooth, and I'll show you why shortly. And we need to recognize that those preparations need a certain amount of tooth reduction. Not only that, at the day of preparation, we need to decide whether we're going to use a cement and glue them in, or are we going to use a resin bonding system to bond them in? Because Emax indications have changed a bit. And really, the cemented version now requires more tooth reduction than the bonded version in the functional areas. And we'll talk a little bit about that. So I can be more conservative if I bond in the restoration. So we decided to do a couple of things with this case. And this case is about 9 years old now. And I used at the time what was called a combination of an HT ingot on 7, 8, and 10, and an LT ingot on number 9 to help me block out this relatively dark endodontically treated tooth. Now, when you have a situation like this, using a masking medium is highly unpredictable, but by being a little more aggressive on the facial aspect of this crown preparation, and then selecting an ingot like an LT ingot, you'll be able to mask this color quite a bit. These teeth were more conservatively prepared with microcopies 11, 16.8 coarse burr, and then finished with an 11, 16.8 fine burr. And I'll show you those shortly. So we do these preparations and we get our final results. Now, being critical of our own work, I think my ceramist did a beautiful job on these teeth, making them match the lower anterior teeth. But if you look at this one here where I'm using a slightly less translucent ingot to mask the color, it is slightly brighter. The reason being is that's the LT ingot. What Ivoclar's introduced more recently, and I would have used that 9 years ago if it was in existence, was what was called an MT ingot, the medium translucency ingot, which would have done a beautiful job in masking this out and had the appropriate amount of translucency. Well, with that said, I think the before and after really speaks for itself. The patient was quite pleased given the limitations of that extremely dark tooth. And really we were able to correct this area here by removing that old PFM and eliminating that metal shadowing we saw and blocking out the color underneath with that LT ingot. So let's talk a little further about full coverage crown preparations. I think it's really essential that we recognize that Ivoclar itself has changed the indications for posterior restorations and the lingual of anterior preparations based on whether or not you intend to cement or adhesively bond teeth. So if you look here on the adhesive side of the equation, the adhesive protocol requires 1 millimeter of occlusal reduction at the very minimum when you intend to bond in the tooth, and 1 millimeter of axial reduction with at least 1 millimeter of cervical reduction. I'll use that the 8 burr to create that. And when you look now with conventional cementation, what Ivoclar has done is change their recommendation for Emax to a minimum of 1.5 millimeters of occlusal reduction. So the reason I mention this up front is you need to decide at the time of preparation whether or not you intend to bond or cement, because the reality is each of those two decisions with Emax requires a different amount of occlusal reduction. With that said, you have to recognize that even Emax version, the lithium bisilicate, compared to zirconia, we can get away with about 1.2 millimeters of occlusal reduction as compared to a 1.5 with conventional cementation of that. So if I wanted to be the most conservative in my preparations, I'd actually do a bonded Emax restoration. The next most conservative might be a zirconia cemented restoration, followed by a cemented Emax restoration. So I'm a big bonder of Emax. I think it's appropriate. I think you increase the likelihood of success with the restoration, and you can be far more conservative in your preparations. Now, let's talk a simple armamentarium for posterior crown preparations. For me, it exists with only two burrs. The first burr is a round end taper burr. It's that 1116.8 coarse burr, followed by a 1923 coarse burr for the occlusal reduction of the preparation. And really, I use these two burrs exclusively on anterior and posterior teeth, and my armamentarium for crown and bridge work is quite simple. To that, I will add one additional burr for smoothing off margins that we'll talk about shortly. So remember, those of you trained on PFMs, we wanted sharp line angles, and the reality is that no longer exists in the all ceramic world. And in fact, we want round internal line angles everywhere, and really getting in the habit of moving away from those sharp preparations to rounder preparations will increase the ease of restoration seating, and more importantly, diminish the potential for fracture propagation generated from some of the forces at these contact areas. Now, I think it's really important that we recognize that one of the biggest problems that we face as clinicians with all ceramic restorations is porcelain fracturing. And I call on my friend Mike Totola, who's a great clinician and has worked for Glidewell. He's worked for Sirona, Dentsply Sirona. And when he was at Glidewell, he made some very important observations. And he said the average dentist is a chronic underpreparer. The average dentist does not know what a 1.5 millimeter and a half looks like. And he said, I know that because I'm a dentist. It's the bane of the laboratory. So most laboratories will report to you that the number one problem they face is chronic underpreparation by clinicians, which really sets us up for clinical failure. What will happen is your ceramist will make your restoration, you'll try on that restoration, you'll either cement or bond it in, and then you run the risk of having premature failure from fracture propagation. Now I'm going to show you a couple of instruments that I think are really handy in the assessment of occlusal reduction. This is a system from a company called Contact EZ, who are really known for proximal stripping devices, but they've developed these gauges, and these gauges are 1.5, and 2 millimeters thick. What they're designed to do is to lay across the occlusal, and from the central groove, you can pass this to the lingual, and you can pass it up over the buccal with the patient's mouth closed. If you're able to slide it all the way through, then you've got adequate reduction. You can then flip it over and do the same thing on the distal aspect. So the patient closes, and you're able to now see if the teeth are being held open in the central groove, and can you pass through the proximal. This is a real nice way of measuring that 1.5, or 2 millimeters of occlusal reduction. The next little trick I can give you is from another company called Common Sense Dental Products. And these are little bite tabs that you'll put in between your preparations. Now these are a little differently. They come in a pink version that's 1 millimeter thick, a green version 1.5, and a blue version that's 2 millimeters thick. What you do with these is you instruct the patient to close onto this tab, and this tab contains a marking media. So if the patient closes and they don't hit the tab, it will not transfer a marking media. However, if the occlusal reduction is inadequate and you're using a 1.5 millimeter gauge, what will happen in the inadequate area is it will transfer a little mark to indicate precisely where you need to modify your preparation. So either of these two devices are quite handy in assessing occlusal reduction on your preparations. So let's talk a little bit about veneer preparations. I think veneer preparations are really difficult, and before you begin the procedure, you're going to want to ask yourself several questions. And this is a process I go through each time I'm preparing a veneer case. First of all, do I intend to lengthen or shorten the appearance of any anterior teeth? If the answer is yes, the prep must wrap the incisal edge. If the answer is no, we can be far more conservative and do facial reduction only. The next question I ask with veneer preparations is, will any incisal embrasures be repositioned mesiodistally? Meaning, am I trying to move the midline? Am I trying to move an embrasure? If the answer is yes, then you need to break proximal contact. If the answer is no, the position of the incisal embrasure is appropriate, then we know that we can get away with a more conservative preparation. And then finally, are there black triangles present to close? If the answer is yes, then I consider moving the margin slightly subgingivally. If the answer is no, there are no black triangles, I will keep the margin supragingival or equigingival. And those are important questions to ask. So here's an example of a case that's been prepared for ceramic restorations. In this case, this is going to be kind of a modified veneer / onlay. And if you notice, this cusp has been beautifully rounded. The occlusal portion is nice and round. There are no sharp point angles. This tooth here has been prepared for an all ceramic crown, and we'll go over those criteria. These anterior 4 have been prepared for veneers with incisal wrapping. Because of the diastema closure intended here, this mesial margin here and this mesial margin here are subgingival. The facial is equigingival, but interproximally it drops subgingival. Same thing right here to close this black triangle, and that's important to recognize. So here's a case where when we do our pre-assessment, we say, okay, do I have black triangles to close? Well, essentially, no. That's question number 1. Will I migrate incisal edge? Apically, yes. I'll have to either lengthen this tooth or shorten this one. So both these preparations will require incisal reduction. And then, am I moving embrasures left and right? The answer is no. So here's the case prepared. It's very important that you take your stump shade. Notice one tooth is darker than the other. That's due to trauma as a child. So to do these veneer preparations, this simple, we need two burrs. First of all, I'll use, again, my workhorse burr, the 1116-8C, a coarse burr, to do my reduction. If you notice here in the distal, I've got my interguard in here, and it's been hit by my burr. Well, honestly, I'd rather hit an interguard than the adjacent tooth. But that allows me to come along here equigingivally and prepare into the proximal to establish that little S preparation here without damaging the adjacent tooth. Let's look at another clinical case. This clinical case, we have to ask ourselves, the three big questions. Number one, will I lengthen or shorten the incisal edges of any of the teeth? Well, in this case, you can tell that these incisal edges are damaged, so I will in fact wrap the incisal edge. Number two, do I intend to migrate the embrasure space on any teeth? Well, I'll give you a hint. I did this case with only 4 preparations. The patient was okay with maintaining a slight diastema, wanted it reduced substantially. So I needed to migrate this embrasure mesially, which means I will have to break contact. And in this case, I'll break contact favoring here and favoring here on the central incisor so I can mesialize both laterals. The next question you ask is, do we have any black triangles to close? And in fact, we have this huge space. It's more like a black rectangle, but we'll call it a triangle. We've got to close this, and we'll do that by dropping our prep subgingival here. I'll place a cord. I'll use Microcopy's 11/16 burr to prepare those margins. So here's an example of preparations for a case just like this, where we're going to break contact and we'll drop this mesial preparation just slightly subgingival to be able to close those spaces. Now, keep in mind, I need to know what my ceramist will make as the final definitive restorative material. And I know my ceramist is a presser, not a miller. So in the case of veneers, I can be a little bit more conservative if I needed to. Really, ideally, I'd like to have these pressed out at about 0.5 millimeters. So I'll use my 11/16 burr to do that. But keep in mind that the CAP requirements are slightly greater if you're trying to be very conservative with your restorations. Now, if you look, here's the completed restorations, both inner mouth and a full face view and this 1:2 view. And we've been able to mesialize everything and create the illusion of an interdental papilla and really greatly decrease that diastema by using and answering those 3 very important questions about preparation. Number 1, am I going to lengthen or shorten teeth? The answer was yes, I must wrap incisal edge. Number 2, am I going to close black triangles? Yes, in those areas I must go subgingival. And number 3, do I intend to migrate an incisal embrasure? Again, the answer was yes. So in those areas, I have to break proximal contact. Now, let's talk a little bit about anterior crown preparations. And it's important to recognize that I'm going to use the same burrs we've been talking about. And that's the 11/16 8C coarse burr and that football burr to establish that 1.5 to 2 millimeters of occlusal reduction if I intend to cement. If I intend to bond, I can sneak this down to 1 millimeter. I'll use that 1923 coarse burr to do my reduction on the occlusal aspect. The other burr I like to introduce for my preparations is a fine diamond burr to just go ahead and refine that margin area. So in the cervical third, I'll come back in and roll over my margins with an 11/16.8 fine burr. It's going to be a red straight burr. It's the same design as the coarse burr, and that really helps smooth your preparations. So take a look here. Here's a case that was completed with just those 3 burrs, the 11/16 coarse and fine, as well as that 1923 football diamond burr. Here's the case after a 5-year recall. This happened to be a zirconia restoration, and we've really established ideal margin adaptation. So let's talk about fixed dental prostheses or fixed partial dentures, a bridge, just briefly. If you're using ceramic, again, remember that the Microcopy Neo Diamond burrs are going to be the same for me again, that 11/16 and that 1923. Keep in mind the amount of occlusal reduction, if it's zirconia, can be as low as 1.2, but really should be in the range of 1.5 to 2.0, especially if we're using the more translucent version. If we were sneaking down to do an Emax bridge, which I'm really not a huge proponent of, you could do a slightly less occlusal reduction. But I'll usually err towards zirconia preparations when I'm looking at bridge work. And in this case, we'll complete that with the neodymium that I suggest. These margins are then created with the neodymium, and allows the milling machine to mill me out a restoration that's acceptable. Now, a couple of things with your occlusal clearances. Remember, keep that bridge preparation of 1.5 to 2 millimeters of occlusal reduction. Keep a nice round chamfer or modified shoulder using that 11/16 burr, and make sure that your connector height is adequate for the restorative material you select. So really that requires you measuring from the terminus of your preparation to the occlusal table, and assume that that's going to be your connector height when you're doing your preparations. So with that said, I hope this has been informative. I'm going to look at a few questions. But before we do that, I want to suggest to you that you can visit microcopydental.com and go on there, and you can go on and click on the product sample page. And if you click on the items you want to sample, for instance, the carbides I discussed earlier, or the polishers, or the diamonds that I suggest, you click on those and you'll fill out a form, and you'll be able to get a sample of the burr sent to you to give them a try. I'm a big proponent of their burrs. I think they're exceptional products and really work out quite well. Now, Amir asked me a question about how do you avoid hitting the adjacent tooth? And I think that's a real important question. And Amir, I think the best way to do that is to use the product I described called an interguard. That interguard will really protect the adjacent tooth. And remember, those are autoclavable and can be reused. And that product can be purchased through a company called Ultradent. Richard, thanks for the positive comment on a good logical presentation. I appreciate that. Gordon's question was, in a class 5 preparation, do you slightly undercut for retention? And really, I don't, Gordon, unless the decay has created an undercut. If the decay or the lesion has created an undercut, I'll go ahead and leave that. But really, I'll rely on my adhesion with a good self-etching adhesive to help us out with that. So I hope that's informative. So let's look at a few other questions and see if I can answer those. Thanks again, everybody, for the very positive comments. Do I use end cutting burrs? And the reality is the only time I'd suggest using an end cutting burr is if you're doing a shoulder type of preparation for, say, a ceramic onlay. And that's where you may use an end cutting burr, but in reality, you can get the same effect with a round end shoulder burr like an 847, and really stay away from getting multiple burrs in your armamentarium. So thanks for that question. What to use for second molars? Well, you know, I'll use, Victor, thanks for that question. I'll use for second molars a short shank 330 burr. You can get those through microcopy that allow you to do that pretty easily for my direct restorations. And really, I've been known to cut off the shank of my 11/16 burr. If it just isn't short enough, I'll take an old carbide burr, cut off the shank, and I'll have a burr that actually works quite well for that. So thanks for that question, Victor. So with that said, we've just got about 5 minutes left. Let me make sure I've got to most of the questions. So how do you feel about feather edge crown prep margins? Well, Susan, this is a great question. I think they're just fine if you're doing metal restorations like a gold restoration. That'll work out beautifully. But the reality is, in today's modern ceramics, most of the time ceramics can't press or mill to a feather margin. And in reality, if you look, really the best you get out of Emax or even Empress would be a 0.3 millimeter margin. So pressing really doesn't work out well in a feather situation. So go ahead and use your feather design for your metal, but keep away from the feather design in your ceramic restorations. So Johanna has asked me a question about desensitizing, and really, do I use desensitizers before the final impression? I generally don't. I won't use those. I'll use a bonding agent at the delivery, but I won't use a desensitizer prior to bonding my preparation. I actually rely on self-etching technology, which really, if you look at it, usually contains HEMA or Gluma in some capacity, which is a desensitizer, to really help with those preparations. So, hey, everybody, thanks for the great comments, positive comments. I hope this was informative, and I want to thank you. Remember, go to Microcopy Dental, look at some of those other products, and you've been great. I want to end this webinar by saying thanks, and follow me on Instagram. I love having Instagram followers. I'm new to Instagram. I'm just building my Instagram world, but you can help me build that world by joining me on Instagram at Marin Dentist or on Facebook at Mark Geisberger DDS. Also, if you have any further questions, there's my email address at the bottom. And if you're looking for a book in aesthetic dentistry, I'm going to give you a very selfish plug. Buy my book, Aesthetic Dentistry and Clinical Practice, through Amazon or eBay. Well, again, thanks and have a great evening. Hope it was informative.